Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
We're going to demonstrate a device called a Jankelson Myomonitor. It is an electrical stimulator which is theoretically supposed to reach a Myo-Monitor Centric insofar as the jaw is concerned. While the actual Myo-Monitor Centric is rather vague insofar as the manufacturer's literature is concerned, there is some evidence that it is somewhere around rest position. We know that it's not centric relation. We know that on closure that the contact made with teeth is somewhere around centric relation, usually anterior to centric occlusion, possibly anterior to this, depending upon the position of the head. We have been doing some research into this area, and Dr. Amin today is going to demonstrate some of the mechanisms of the instrument and how it works, and afterwards we will have a short discussion about what he's found.
The first that I would like to show you today is the instrument itself and the dials or gauges that are used to adjust the instrument. Here in the upper left-hand corner, the output selector is used to determine which side the input of current is placed to the patient. Through this cord, the instrument is connected to the patient. As you can see, we have surface electrodes placed bilaterally, one on the right side, one on the left side, and also one placed posteriorly at the nape of the neck. Thus, through this dial, we can vary the current through both input electrodes or to either right or left. This amplitude dial in the center is used exactly for that purpose, to vary the amplitude as required by the individual patient. The dial at the base in the center of the instrument is called the balance dial. If there are unequal contractions of the masticatory muscles, either on right or left sides, this dial can be used to vary the input of current either to right or left sides. The switch located here in the left-hand corner is the pulse and test switch. The pulse switch is activated when we wish to make determinations of the Myo-Monitor Centric. The overclosure dial is located in the upper left-hand corner. This dial is used only when efforts at getting the patient to have tooth contact during the Myo-Monitor recordings fail. This dial may be activated and closure beyond the normal position may be produced. The dial at the top of the instrument is used to indicate the level of current flowing through the patient and also the activation of the pulse circuit. The manufacturer has suggested several uses for this instrument. However, today we're going to be concerned primarily with its use in occlusal adjustment. It is recommended that the patient be seated so that the head is along the line of the body. We then make adjustments, individual adjustments for the patient by activating the test circuit The amplitude dial is advanced until we see the first contraction of any muscles of mastication or facial muscles of the patient. I believe you can see the contractions of the muscles around the eye. It is also recommended that this position on the amplitude dial be left for approximately 5 minutes as a warm-up period for the patient. Since this has already been accomplished with this patient, we will proceed with the further adjustment of the instrument, which includes advancement of the dial by 2 degrees from the initial position or the threshold position. We now have initial tooth contact. This is then an intermittent muscular contraction and movement of the mandible to tooth closure. The instrument may then be adjusted by placing it to the test circuit, which inactivates the muscular contraction. The method that we are going to use today to illustrate occlusal contacts is that with occlusal articulating paper. I'm going to place this paper interocclusally, activating the test circuit and allowing mandibular contraction. If contact with the normal circuit is not strong enough to produce contact of the teeth and marks with the articulating paper, the overclosure dial may be activated in order to produce a stronger, harder contraction of the muscles. I'll illustrate that now. It is recommended that the amplitude dial for the overclosure circuit be advanced 1 degree. Now, a picture of the patient's face will indicate that the contractions are somewhat more severe. Through this method, the articulating paper has marked what the manufacturer terms the interfering contacts along closure into the Myo-Monitor Centric. Primarily, we have found that the occlusal contacts with the Myo-Monitor have generally been in anterior teeth, and our studies with the instrument seem to indicate that this position is at least in the area of centric occlusion on an antero-posterior basis, and most often anterior to this position by some degree. If these contacts can be shown, I guess it is rather difficult to see. They're primarily located on anterior teeth, while the posterior areas do not indicate the intensity of contact. Another one of the adjustments that the manufacturer has recommended in occlusal adjustment is the use with these articulating materials of the output selector, whether we have input to the muscles on the right side or to the left side. It is recommended that the both selection be used for 30 seconds and then transfer of the impulse to first the left side for several contractions, and then to the right side. Most of our patients have complained of discomfort during activation of the overcloser circuit due to the intensity of the muscle contractions. Again, we find primarily that the tooth contacts are located in the anterior areas. It is suggested by the manufacturer that these contacts, which interfere with closure into a solid Myo-Monitor centric, be eliminated until there is even contact throughout the mouth.
Jack, you've been using this instrument for some time now. Have you ever found it to register centric relation contact?
No, the contacts produced by the Myo-Monitor have always been in an area anterior to centric relation. This has generally been found to be in the area of centric occlusion or a position slightly anterior to that.
How consistent does this instrument work?
Our consistency was measured in a matter of millimeters or parts of millimeters, and it was found generally that 9 separate Myo-Monitor registrations had a definite degree of variation. It always produced a pattern which was relatively close. However, there was always some variation, and the reproducibility was not something that was remarkable.
Was this from day to day and from the same time period?
The studies that we did were of the order where we took 3 Myo-Monitor recordings at each of 3 different appointments in order to test whether there was variation on a particular day and also if there were variations over a period of time.
Was this variation anterior posteriorly, laterally?
The variation seemed to occur in all 3 dimensions. There was no one dimension that seemed to be more stable as far as reproducibility was concerned.
Would you think this device would be of any value in the way that we do occlusal adjustments at the University of Michigan?
I don't believe so. There is the tooth contact produced by the Myo-Monitor always seems to occur on anterior teeth, and adjustment of these teeth in order to produce a stable Myo-Monitor centric would result in it appears to me anyway, gross reductions of anterior teeth, which we don't teach here at all.
And you'd still be leaving the premature contacts.
Exactly. The premature contacts and centric relation would still remain. There is no way that they can be eliminated using the myocentric.
Is this device any good for lateral?
The lateral excursions were not tested too thoroughly. However, it was felt primarily that the interferences in the Myo-Monitor centric were so great in the anterior-posterior regions that lateral excursions weren't really indicated. We actually didn't go beyond the straight-ahead centric relation, or excuse me, Myo-Monitor centric.
How would you define Myo-Monitor centric on the basis of what you've done?
To me, it does not seem to be an exact or reproducible position that can actually be defined. It appears that it varies from patient to patient, definitely, and also within patients from time to time. The position appears to me to be somewhat slightly anterior to a centric occlusion position, what we know as centric occlusion, and it also is somewhat an open position in a vertical dimension.
If you wanted to do this technique, what kind of a price would you have to pay for that instrument?
I believe the instrument is priced at somewhere in the neighborhood of $1,100.
Do many people seem to be using it?
I have heard reports that there are several prosthodontists who have had some good results with it. Since this instrument is supposed to produce a position which stops at the correct anteroposterior and vertical dimension, the prosthodontist is somewhat free to work with these dimensions in his construction of dentures. And I have heard reports that several individuals, especially in California, have used the instrument with some success.
I notice in the manufacturer's brochure that they talk about this device giving you the correct interocclusal space. What do you think about that?
The correct interocclusal space referred to by the manufacturer seems to be a rather strange expression of this concept. They feel that if tooth contact is not produced by the Myo-Monitor, that there is an excessive freeway space, and that this hopefully can be corrected by allowing the teeth to hyper-erupt to reduce this interocclusal dimension. As far, again, speaking in terms of the prosthodontist, the position produced by the Myo-Monitor in a vertical dimension may be used simply because they have the leeway to establish the vertical dimension at whatever height they feel is correct for the patient.
Well, how would you get a registration of the jaw for that centric that they're talking about?
The centric that they're talking about is registered by using an acrylic material which is self-curing. Liquid and powder are mixed together and placed. Since we worked with dentulous people, we used a mixture which was placed on the occlusal surfaces of the patient. Closure with the Myo-Monitor into this acrylic material until it began to harden was used as a recording medium. This acrylic material was then removed from the patient. It was trimmed and allowed to bench cure between models recorded previously of the patient. This was the recording that was used, or this was the Myo-Monitor centric recording.
Then you'd have to use an articulator and mount the maxillary cast with
Exactly.
that. Would that be on what axis now? Certainly wouldn't be centric relation, would it?
This is something that I have yet to completely understand. The manufacturer also recommends what he terms a terminus precise articulator, which appears to be a completely or relatively completely non-adjustable articulator, which closes only on a hinge. There appears to be no or very little adjustment for lateral excursions. The manufacturer suggests that this articulator can be used to maintain the proper vertical dimension and also anterior-posterior relationship of the mounted cast for reconstruction to that position.
Sounds like it's a hinge-type articulator.
Yes, it is.
The mounting would be open around centric position and would certainly be somewhere in the neighborhood of rest position vertically.
It would appear to be.
So on closure, probably be some, if there were teeth present, some opening in the posterior region there.
Yes.
Lack of contact.
Yes. This is only with a natural dentition. However, if the teeth were placed so that reconstruction was done to the Myo-Monitor Centric, definitely that posterior closure that you just mentioned would be reconstructed so that there was posterior closure.
One final thing, Jack. I'm amazed that since this has been in use for, perhaps 2 years now, that I haven't seen anything in the literature with a reference to the claims made by the manufacturer, nor clinical studies relating to how effective this instrument is for occlusal adjustment, or how effective they might think it is, or for the effectiveness in making complete dentures.
Checking the literature, as you say, revealed no studies that have been done recently or at any time. When I contacted Dr. Jankelson by personal communication concerning studies that might have been done and not published, I received a reply which indicated that several electromyographic and other studies were in print or being conducted at the present time. However, Dr. Jankelson had published no reports other than that accompanying the instrument in the form of a manufacturer's recommended instruction manual.
Do you think that this is the instrument he referred to back in about 1962 relative to his automatic technique for doing an occlusal adjustment? And I believe at that time he was doing his adjustments from centric relation.
Exactly. In the Dental Clinics of North America, there was an article which was concerned with an automatic relation producer, relation finder, which he briefly mentioned and stated that this would replace or rule out the
Jiggling.
Problems. Yes.
Rule
yes.
out our jiggling technique?
Exactly, and it would rule out the difficulty associated with achieving a correct or accurate centric relation determination.
I see now, though, his must have a different concept of doing an occlusal adjustment to match this particular device, because obviously it's not registering centric relation.
Yeah, I would believe that's true. At this time, as you said, in 1960, he stated that this would produce centric relation and there would no longer be any problem registering centric relation. However, we've found through our studies that this instrument does not produce a centric relation recording.
Well, thank you, Jack. We're going to wait for your publication to learn all the details of this instrument.
Okay.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.